Hi, this is Manos Brilakis presenting video 8.3.2 for the Manual of CTO Interventions. This is a video discussing the retrograde approach using septal collaterals. There are 10 steps to the retrograde approach, and in this video we will cover the first 5 of them as they apply to retrograde through septal collaterals. The first one is to decide that the retrograde approach is the next step during the procedure. Based on the global CTO crossing algorithm, there are certain anatomic characteristics that favor the retrograde approach as long as the retrograde approach is feasible, and those are proximal cap ambiguity and poor quality distal vessel. But of course, the retrograde approach can be used in patients in whom the antegrade crossing attempts are not successful. The second step is to select the collateral. And septals are actually the most commonly used collaterals in about 60% or more of most CTO registries. And the reason for that is that they are more favorable than epicardial in terms of safety and complication. If a perforation happens in the septal, as we'll discuss, usually there are no significant consequences, whereas for epicardial, there is a high risk of tamponade. So when do we use the septal collaterals? We most commonly use them to approach right coronary artery CTOs. And then we use septals from the LAD that go usually to the PDA and then cross the CTO retrogradely. But also, the septal collaterals can be used for going the other direction, for crossing LAD CTOs, going from the right coronary artery through the PDA into the LAD. And finally, we can use septal collaterals going from the LAD ipsilateral to the LAD. They are often these ipsilateral septals connections that can help cross an LAD CTO. Wiring those collaterals is easier coming from the LAD than when coming from the PDA. And the reason is that the more distal part, the one closer to the PTA, is usually smaller and more tortuous than the part that connects with the LAD. This is an example of septal collaterals. We want to do good injection and study the collaterals. And the views we typically use to visualize the septals is the RAO view or the areocranial, with the areocranial being better for visualizing the origin of the collateral from the LAD, and the plain RAO being better for visualizing the more distal part where the septals connect with the PDA. Quite often there are more than one septal collaterals, and in general we want to use the ones that are larger with less tortuosity, and also the ones that enter further down from the distal cap. And it is a good habit to grade the collaterals in terms of appeal for using the retrograde approach, so one has a plan before going into the procedure. The proximal septal collaterals sometimes may connect to the right posterolateral. And this is an example where the septal actually is connecting to the posterolateral. Going to a more proximal septal has the other advantage that there is more short connection, so there is less issues with running out of guidewire, although this is less likely these days having the R350 and the RG3 externalization guidewires. So in terms of choosing the collateral, the key parameters are the size of the collateral and the tortuosity. This is true for both septal and epicardials, and there are 2 scores, the J channel score and the CC score, for determining the likelihood of crossing the collateral. From those 2, I believe that the CC is more easy to remember and more practical, gives 1 point if you have a large collateral, and 2 points if you do not have any significant tortuosity, and the more points you have, the more the likelihood of crossing the collateral. However, even when we do not have any visible collaterals, that's the so-called invisible collateral, quite often in more than 80% of cases, those collaterals can still be crossed using the surfing technique, which we will discuss later on. This is an example. This is a septal collateral. We don't really see contrast going all the way to the PDA, but then we tried with a SUO03, which is a soft non-polymer guidewire, and the wire actually eventually successfully found a way and successfully crossed into the right PDA. So sometimes it's worth to try to cross even those invisible septal collaterals. Moving on to step number 3, which is to reach the collateral. And when we say reach, we mean to advance a microcatheter into the septal, so then we can use a guide wire to cross the septal. The key concept here is that if there is significant disease proximal to the takeoff of the septal, then that needs to be addressed first, because advancing a microcatheter over it might cause ischemia and cause problems. Also, if you have a previous stent that is jailing the origin of the septal branch, as for example in this patient, then it is important to perform balloon angioplasty with a small balloon, usually 1.5 or 2.0 millimeters, of the origin of the septal to facilitate advancement of equipment inside the septal and reduce the risk of having entrapment of equipment inside the septal. And again, the goal is to avoid complications like this, that there is dissection or other issues in the donor vessel. So again, if the vessel needs treatment, the donor vessel proximal to the takeoff of the septal, then this should be done before crossing the septal. When it comes to actually advancing equipment, we typically use a workhorse guide wire advanced through the microcatheter. And we often put a double bend that can help direct the guide wire into the septal, or a large bend. And if that doesn't work, for example, if the collateral comes at an angle or it is difficult to engage, then there are different ways to get in there, such as using a polymer jacketed guide wire, using an angulated microcatheter, such as the Venture and the Supercross, or using a dual lumen microcatheter, and finally using the reversed guide wire technique. And this is an example in which we actually ended up forming a loop into the guide wire, and then coming back with the loop, the guide wire entered into the septal branch. So this is the reversed wire technique that is done with a polymer jacketed guide wire. This is an example in which we have a dual lumen microcatheter, where the one operator is moving the dual lumen and the other operator is probing, and then eventually we find the origin of the septal, and the guide wire goes inside the septal branch. This is another example in which there was significant disease proximal to the takeoff of this septal branch. So before going retrograde, we placed a stent, and then we were able to advance equipment. Moving on to step number 4, which is crossing the collateral with a guide wire. So this is where we are. We have advanced a microcatheter inside the collateral. Now we're trying to cross it. And the crossing requires two things. One is the microcatheter, the other is the guide wire. Also, if we suspect that there may be difficulty delivering equipment retrogradely, it may be worthwhile starting with a guide extension in the donor vessel. Of course, this can be placed later on if there are difficulties with delivering the microcatheter or advancing the guide wire. In terms of which microcatheter to use, there are several different types, but essentially we're using the single lumen, 150 centimeter long, very important to have long length, not 135, but 150 centimeter long. And those can be either the larger ones, such as the Corsair and the Turnpike, or the smaller ones, such as the Caravel, Corsair XS, Turnpike LP, and the Fine Cross. The smaller the collateral, then sometimes the smaller microcatheters can be more likely to cross. However, those provide less support than the larger ones, such as the Corsair and the Turnpike. How about guide wire? There are different wires highlighted in yellow that can be used for crossing the septal. The most common ones are the SU03 and the Sion from the hydrophilic wires without polymer jacket, as well as the Samurai RC. When it comes to the polymer jacket wires, the Sion Black and the Fielder XTR are the most commonly used. In my opinion, it is best to start with a less traumatic wire, such as the SU03. The SU03 has 0.3 gram tip load, and therefore it is less likely to injure or dissect or perforate the collateral. So it is usually my first choice for going through collaterals. But if there is difficulty or tortuosity using the polymer jacket wires may work. Some operators also use the Xeon guidewire or the Samurai RC, and typically we place a small bend, 1 millimeter, 30 to 45 degrees at the tip of the wire. In terms of the technique of crossing the septal, there are two broad techniques. One is called the septal surfing, developed by George Shanus, in which we advance the wire without contrast visualization prior to advancing the guide wire. And the other one is the contrast guided, in which we do selective injections of the septal through the microcatheter to find the best possible route for advancing the wire. The surfing technique is mentioned before, developed by George Shanus, and that has really helped streamline crossing the septals. This is how this is done. We do not use a torque because we want to advance the guide wire and rotate it very quickly. And if there is a torquer here, then we cannot rotate it as quickly as we could otherwise. But essentially, this is a combination movement of rotation. We are rotating the wire between the thumb and the index finger, and then advancing back and forth. If the wire buckles or feel resistance, then we pull it back and we redirect. And we definitely do not want to push hard. This should be something that is very easy to advance. The wire should feel like butter. If there is resistance, we pull back and redirect, and it's not uncommon to have PVCs. So having PVCs doesn't necessarily mean it's something bad. It's very common, even when you cross to distal true lumen, to have PVCs when crossing septal collaterals. And these are some examples of the surfing technique. We're advancing the guide wire, and eventually the guide wire finds its way, and then now it's moving along the course of the right coronary artery. This is another example with the filter XTR. Again, we're advancing, the wire is not going, it's getting stuck, and then eventually we're advancing in another direction. Now it finds a way, and then eventually the wire goes along the course of the RCA. And this is another example, a Xeon black again guide wire, in which the wire takes different courses, and eventually we're pulling back and forth. Again, this simultaneous rotation, but you cannot really see the rotation because the tip is very short. And then this can happen actually fairly quickly. Speed is your friend here because it reduces the friction and make it easier to find the pathway. And then eventually the wire goes into the course of the RCA. And here is yet another one. Sometimes the septal collaterals can be fairly tortuous, but the wire may follow an unanticipated course. So typically, we want to see the wire go towards the apex and then turn back up. This is the most common course where the wire is going. This is an example of the contrast-guided technique. We advance the microcatheter inside the septal, and then we connect a 3 cc medallion syringe. Medallion is less likely to break compared with the standard 3 cc syringes because we do exert quite a bit of force. We aspirate. We want to see there is good blood coming back into the syringe. And then we inject. And sometimes it may take some force to actually get the contrast to go. Under simultaneous visualization, we typically do cine angioscopy for that. And then before advancing actual equipment, we take another 3 cc syringe and we flush the microcatheter with saline to minimize the friction and the stickiness of the guide wires going through the microcatheter. And this is an example. Here we actually have a venture, which we don't commonly use these days, and we're injecting inside the septal branch. This is another example. We have a microcatheter, we're injecting, we're seeing that there is this septal collateral going in the right direction, and then we use guide wires and try to follow the same pathway. Sometimes, if there is difficulty advancing the septal guide wire, then what we can do is do injections in different projections, LAO and RAO, because sometimes tortuosity may not be visible on one projection, such as the RAO, which is the most commonly used, but may be much more visible on the LAO projection. So different projections if there is difficulty crossing with the septal. And in general, the surfing is what most people do first because it's much more efficient and it succeeds in, I would say, most of the cases. But the downside of the surfing is that there is a risk of septal injury, and that's especially true if we're using polymer jacketed wires such as the Xeon Black or the Fielder XTR. The advantage of the contrast guided is that there is less risk of injury because we're controlling where we're advancing the guide wire based on our selective tip injection of the septal collateral. So what to do if we cannot cross a septal? The typical actions are to use a different guide wire. So for example, if we start with the SU03 and it doesn't work, we can switch to a Xeon or a Xeon Black or a Fielder XTR. The other option is to slightly change the bend at the tip, put a little more or a little less bend. And then if there is difficulty, then we can do some contrast injections. Be careful when injecting after doing surfing, because if the wire has gone out, there's a possibility that there may be some leaking, some small microperforations of the septal that may enlarge with forceful injection through the collateral. But if everything fails, then the solution is often to use a different collateral, and this, fortunately, is often true for septals. We often have more than one septal that can supply the vessel, and this is also an advantage because we're less likely to experience ischemia when crossing septals, because typically we have multiple. Whereas for epicardials, if there is a single large epicardial, it is more likely to develop ischemia after trying to cross the collateral and compromise the undergrade flow. So here, we changed the wire, we used the SU03 in this case, and eventually we were successful getting through. This is an example of what we mentioned before about ipsilateral septal to septal. We did the contrast guided. We see it's a fairly tortuous, fairly small connection going up. But then using the SU03 guide wire, we were able to negotiate this bend and then advance the microcatheter and then cross the LAD CTO retrogradely. If that happens, then one needs to use the ping pong guide often, second guide, because externalizing within the same guide catheter can have issues with the equipment. And moving on to step number 5, which is to confirm the position of the guide wire into the distal true lumen. This is critical for every crossing, including the septal. Here we see that although the wires seem to be going somewhere, when we inject, it is actually outside. And we could have suspected this because the wire is not straight. You would expect if the wire goes into the PDA, for example, then the distal part would be straightened and following the course of the vessel with a back and forth movement. But here, the wire is actually still curved, still bent, even though it should have been straight into the PDA. So in this case, we pulled it back, we redirected the guide wire, and now you see how the guide wire is straight. There is this back and forth movement, and the wire is moving along the course of the vessel. But you want to confirm this before advancing a microcatheter. If the wire goes out, it's usually not a big deal for septals, but if the microcatheter does, that can be more serious. Another potential challenge when crossing septals is when the guide wire crosses into the distal vessel, for example, the PTA for RCA CTOs, but then the wire, instead of going more proximally, wants to go more distally. And this can happen sometimes depending on the angulation at the touchdown of the collateral with the PDA. So here, the wire is actually going towards the apex of the heart instead of going retrograde. And one way to deal with this is to bring the microcatheter back down and then try to use different guide wires with different bends to redirect the wire. This is what we did. We pulled it back, we used the Fielder XTR with a different bend, and we were finally able to redirect it. So now it's going proximally instead of going distally. We will finish with some comments about complications of septal collateral crossing. The first one, which can happen with any retrograde, is donor vessel injury. This is an example of dissection of the proximal LAD going retrograde to fix an RCA CTO. This is why it is important to have a safety wire. So if this happens, retrograde gear is removed and an undergrade stent is placed quickly, or if it's thrombus, the thrombus is aspirated quickly. So always when doing retrograde, place a safety wire into the donor vessel. This provides access to the vessel in case there is a complication such as donor vessel dissection or thrombosis. The second is ischemia, Again, this is less likely in septal collateral crossing because we have multiple of them. So even if one of them becomes occluded, the other ones usually will suffice to provide good flow to the distal territory. Also, to prevent ischemia because of compromise of the donor vessel, if there is disease proximal to the takeoff of that collateral branch, then we won't take care of that, stent this before going retrograde. When it comes to collateral dissection, that is not uncommon. It can be dissection or perforation. This is the same example of the ipsilateral septal collateral, that actually the guide wire went in a different location, and now we do have actually a perforation of the septal. And the downside of that is that then the collateral is compromised and often we cannot use it. But in this particular case, we could still see the connection going to the LAD, and then using the SUO3, which is again very soft atraumatic guide wire, we were able to negotiate follow a different pathway for this septal branch, and we were able to get it to actually go towards the LAD. Collateral perforation, again, is not usually a big problem, but there are a few cases in which it can cause a large septal hematoma that could impair filling and that can lead potentially to cardiogenic shock. If this happens, the treatment is using a stiff guide wire to try to fenestrate, to open that hematoma into a cavity. So this way, there is less accumulation inside the body. Rarely, an septal collateral may become an epicardial, and that might lead to tamponade, and if that's the case, then that collateral needs to be closed, usually with coils. So this is here an example in which we do have crossing of what we thought was a septal collateral, but then if we look at it, the vessel the wire doesn't look good. And then when we took a picture, we realized that actually we were outside, so we had perforated. It was not a septal, but it was an epicardial collateral. So we got fooled by using the aerial projection, illustrating the importance of using orthogonal projections. And then we eventually had to place a coil to seal off this epicardial collateral that had been damaged. When it comes to microcatheter entrapment, this can happen. So when manipulating the guide wires, it is important to keep the tip free to avoid having knots in the guide wire, because then it can get entrapped. Also, other equipment such as the microcatheter can be entrapped. This is an example of doing CTO PCI through a septal that had been jailed with a previous stent. We were able to get the microcatheter down, but then we could not move it. Somehow it became entrapped inside the vessel. We ended up cutting the microcatheter. You can see the proximal end, advanced guide extensions, and eventually what worked here is advancing a second guide wire, performing ballooning, and then advancing a guide extension over both the entrapped microcatheter and the second guide wire, and that eventually resulted in successful retrieval of the entrapped microcatheter. This is another example. This is a retrograde crossing of a very calcified right coronary CTO. We ended up snaring and externalizing a guide wire. This is a Gladius Mongo, but then couldn't deliver anything undergrade and could not remove the guide wire. The guide wire became entrapped. Eventually, the patient had to go to surgery. Another option for cases like this is to use a rotablator to cut the wire that might facilitate retrograde retrieval. And finally, what can happen is a fracture of the tip of the microcatheter that typically doesn't happen inside the septal, but is more likely to happen distal to the touchdown of the septal into the distal true lumen. So to summarize, septal collaterals are the most commonly used collaterals for retrograde CTO crossing. If there is disease proximal to the takeoff of the septal, please treat it before going retrograde to minimize the risk of ischemia. When it comes to getting there, we usually use a workhorse and get the microcatheter inside the septal. Then we use 150 centimeter long microcatheters and either the SUO3, which I recommend as the initial one, or the Sion or a polymer jacketed, such as the Sion Black and the Fielder XTR with a small distal bend to cross through the collateral. And after the wire advances to where we think is in the distal true lumen, we always want to do a injection from the donor vessel to confirm that the wire is in the true lumen before advancing the microcatheter over the guidewire. Thank you.